Hi, everyone. Good morning, good afternoon, good evening, wherever you're joining us from. Thank you for joining us today in the fifth webinar in our series presenting project outputs. Today, we will hear from the WorldFAIR case studies on urban health and population health. Some very few quick housekeeping notes before we begin. This webinar is now being recorded. It will be shared on our YouTube channel and our website, and it will be shared with you via email after the meeting. Please feel free to post your questions in the chat during the presentations. There will be a panel discussion and a Q&A section at the very end. So as I mentioned, the fifth webinar from our case studies, and today we are here. We will also hear next week on the 15th from the disaster risk reduction case study. And in December, we will hear from the cultural heritage and social surveys case studies, which will run their second webinar, presenting their second round of published reports. So our webinar series has been running since May 2023, and it will run all the way to the end of the project. These are the webinars in this calendar year. We are currently scheduling the dates for the next calendar year. So please visit our website. You can catch up with the recordings of the presentations you might have missed, and you can also find out about the new dates there. So today, our agenda and speakers. Today, we're hearing first from our case study in population health, which is working on data from infectious disease surveillance and response. So the Implementation Network for Sharing Population Information from Research Entities, or INSPIRE, is assembling technologies and standards in support of a data hub that facilitates federated and shared research capable of interoperating across often neglected low-resource settings. So INSPIRE uses OMOP, which is a common data model, the gold standard for systematically integrating health data from disparate sources. Currently noted not to be completely fair. Further work is needed to improve the ability to integrate diverse sources of data, and this case study is working on exactly that, improving the interoperation of OMOP with other standards to enable machine actionable descriptions of data structure and provenance. More detail on that from our speakers in a little while. The first published report from this case study, Population Health Data Implementation Guide, describes the way all aspects of data are made available for use, both within and outside the INSPIRE network community, using standard metadata to describe the data. So this is an exploration of how generic standards can be used to express the agreed community metadata sets. Our speakers from today are Jim Todd and Keith Tomlin from the London School of Hygiene and Tropical Medicine. Next up, we will hear from our case study in urban health, the Salary project, which is a 5-year project based at Drexel University, with partners throughout Latin America and the United States. So it studies how urban environments and urban policies impact the health of residents from 11 Latin American countries. So the project has created a data structure that allows incorporation of data from different sources and developed procedures and standards that systematically documented issues related to access, data access, quality, and completeness during the process of data harmonization. This case study explores and further refines this approach to provide recommendations for urban health data that reflect the FAIR and CARE principles and contribute to promote best practices in data sharing and use within and beyond the urban health field. This case study is also working on a training component, which will disseminate the expertise gained during the process of guidelines elaboration, fostering a community of practice within and across disciplines. The first published report from the case study on urban health data, guidelines and recommendations assessed the implementation of FAIR principles within the urban health field through 2 case studies, a focus on data collection and harmonization process of health survey data, which allowed the elaboration of consensus on terminologies and procedures that facilitates the use of survey health data in cities for research and action. Our speakers today, Ana Ortigoza from PAHO and Ron Lee from Drexel University, will give you more detail on that in a little while. After our speakers and the presentations, we will have a panel conversation, which will explore synergies and common challenges identified between those 2 case studies. The panel will be composed of our speakers, and they will be joined by Osama Bilal from Drexel University. After that, we will open the floor up to you, and we will take your questions. So please feel free, as I said at the beginning, to post your questions to the chat. I will now stop sharing, and I will also put in the chat links to the deliverables in the published reports that I mentioned. Now on to Jim.
Thank you very much, and hope you can see my screen now. This is the first part of what we did with the population health data, and I want to take you through some of the ways that we implemented. We had these guidelines for implementation of FAIR principles for population health data, building upon the data that we have in INSPIRE and how that can be used. As Alex said, it's myself, Jim Todd, and Keith Tomlin who will be present this on behalf of the other co-authors to this, Arafan, David Amadi, who's here today, Jay, and Sylvia. And there's the different institutions that are involved in the INSPIRE approach just there. So, as I said, this is part of the WorldFAIR cross-domain model. The INSPIRE project is led by Agnes Chiraga in APHRC in Kenya, and it focuses on population health. And we'll just do a little bit about population health in a minute and say what that involves and how that's different from other clinical health and other things like that. The vision is that we will be able to build a network for both users and producers of population health data, and to create a hub for FAIR data, which will be including the metadata, but also the results from those FAIR data that we have. And this will be able to be used to answer important policy relevant questions that will improve the health of many people in low and middle income countries. So the objective of this particular deliverable was to describe by which population health data can be made fair. And just to say a little bit about population health data, I mean, many of this comes from surveys, from observational data for people living in the community through questionnaires, sample testing maybe, but other forms of testing as well. And much of the data from the INSPIRE network comes from health and demographic surveillance systems, where they're monitoring vital events such as births, deaths, and migration issues, but also including data on the different health outcomes and the different health challenges that people have there. A health and demographic surveillance system has the central cohort of population that is under observation, and they might leave through death and through outmigration, and then new people come into these through births and through in-migration, and people grow older as they go along there. And some of these health and demographic surveillance systems quite large, covering 30 years of health records in the population over urban and rural populations. And people are followed up and identified, and they have respect for being in that cohort. The other thing is that we can gather information on the exposures that they get to those people in their communities, the public health interventions, the community experiences, the environment, the climate that they get, their droughts and excess rainfall, etc. And we can then link this population health data to clinic data if we need be. And we use the network to share good practice and to undertake training in the different data issues that we have here. So the objective here is to build a population health data set, which can be used through a data harmonization model, and it can be a fair or even fairer process for data sharing. The issues that we have here is, first of all, the ethics. How do we maintain the confidentiality of our population under observation? And how do we recognize the value of the data producers who actually produce these data? Second issue is around the infrastructure. What common data model can we use? And how can we then make that common data model, the data in that common data model, visible to those outside the network? We have some issues around policy and governance. Who do we and how do we get people to get involved with that? Not only the users, but the communities, the researchers, and the policymakers from there. And that actually is part of our deliverable 7.3, which we'll be working on later. And practice, using the different tools. How do we standardize and harmonize that data? And also, how do we engage with training of data managers and analysts? And that is actually part of our 7.2 deliverable, which we're working on right now. So I just want to, sort of say that the INSPIRE network uses the OMOP common data model for population health data. It wasn't designed for population health data, so we've had to adapt it in some ways for that. But the good thing is it has a standard set of tables, and these standard set of tables can be used in the same OMOP instances or different OMOP instances when they are federated across different institutions. And we can develop a common metadata and common ETLs, which can be used on all of these different instances. And we can build analysis packages so that we can get particular results using the same cohort definitions within each of our OMOP instances. However, the issue here is that OMOP common data models by themselves are not necessarily fair. The data might be protected through data sharing agreements. The metadata might be available, but people can't see that. So what we need is fair implementation protocols and fair enabling resources to make the OMOP common data model fair. And what I'm going to do now is hand over to Keith Tomlin, who is going to describe how we did this using a particular data set, the IDSR, the infectious disease surveillance and response data. So over to you, Keith. I shall stop sharing and let you share your comment.
Thank you, Jim, and hello, everybody. Let me just go ahead with my screen share now. And I'm hoping you can all see that. Somebody nod. See if you can. Okay, yes. Excellent. So what we did in order to take forward the process that Jim has just described is to take one particular example of primary data collection and to look at a mechanism for putting that into the common data model that Jim has just described, and then also looking at a process of how to make those data fair in terms of our own research, our own domain, and outside of our own domain as well. And what we've chosen to do for this is to use an example from the Integrated Disease Surveillance and Response Program that's run and was devised within WHO. It's a comprehensive program of disease surveillance. It operates within communities and within clinic facilities. It has a number of case record forms. And for this example, we've chosen to use the immediate case-based reporting form. And this is available within one of the implementation guides that WHO have produced for doing this. And so you can see here the nature of what is recorded as part of this case recording. And what we needed to do, first of all, was to place this within the common data model that Jim has described, and then to look at how the FAIR principles could be applied. And my screen isn't moving forward. Here we go. Whoops. So what we have here is a transfer of that form into a number of the component tables that form the common data model. And the deliverable itself that we've produced gives more detail on this and this process, but you can see that there are a number of the common data model tables here. And this diagram illustrates how the data from the IDSR CRF is transferred into those. Each of these boxes represents a table that's within the common data model. And within that, we have primary keys that are colored in orange that hold unique records together and maintain the relational structure of the database. We have foreign keys and questions that are expressed by concepts within the common data model itself. And clearly, this is one of the features of the common data model. If you're familiar with using it, it uses standardized concept IDs and vocabularies throughout. And this makes standardization of data more straightforward, more feasible to carry out. But as Jim said, the process of putting data into a common data model does not, as of itself, make data fair in terms of the principles that lie within FAIR. What we know is that FAIR requires that we provide data in a useful way to those who may not be familiar with the tools and the standards that we've used within a domain, or to those tools that have been used within a research group within a domain. So whilst what we have done may be recognizable to individuals who are working with population health data in this way, the principle of FAIR is that we're able to sort of to move beyond that. And the approach that we've taken is to use a standard called schema.org, which is essentially a structured way of annotating and marking up data on web pages through a mechanism that is very much supported by the major web search engines. So by using schema.org, by using this particular standard, we can document our resources in a way that maximizes accessibility, not only just within our own domain, but to users outside of it as well. And schema.org, it's a standard that's recommended by the Work Package 2 of WorldFAIR as being part of the cross-domain interoperability framework. And this is one of the things that lies at the heart of FAIR, which is the interoperable nature of data within and across domains. Now, in order to do this, we have used a flavor of JavaScript called JSON-LD in order to express our data within the schema.org structure in a way that is both machine readable and machine actionable. And this was initially something that was examined as a study-a-thon carried out by Eden as part of the Innovative Medicines Initiative in 2020. And this was looking at interoperability in terms of the common data model specifically. And by using this language JSON-LD, this particular flavor of JavaScript, it's efficient at embedding information within web pages in a manner that may be hidden to human users, but it is visible to computers. And the aim of this effort was the actual FAIRification of Odyssey data. And even though the goals of this particular study-a-thon were specifically aimed at practitioners in observational health, the techniques that were employed were common to other domains as well. And this is what led to the possibility of interdomain interoperability. There's a small diagram here of a metadata model that has been expressed in schema.org. This was presented in a poster by Emma Voss and Tess Kurtat. And it divides the components of a schema.org schema into two particular types. A literal, which is referring to enumerated values taken from within a list, for example, and then a class, which is a more complex structure containing subfields. And what this helps to address is that within WorldFAIR, it's not only possible that metadata should be readable by machines, but it's also actionable by machines. So, for example, when a program reviews a database against a description of a study, it can potentially invite network study partners to that. So it's a way of revealing data to people who may not normally encounter it. Now, this model can be built out in a substantial way, and here is quite a detailed description of a study package that we have put together that is looking to create the rich metadata around conducting a study of the IDSR type data. This illustration and the description of it, there's a lot more detail of this within the deliverable itself. But essentially, here we're just seeing that our central object here within schema.org is the medical observation study itself, the experiment or the study that's being described. On the right-hand side of that, we have some of the components of that in terms of the descriptive elements. We have a medical risk factor, which is the exposure that we're interested in. And then here, this documents two study designs, a predictive analysis and an incident rate analysis. And what we, in the process of doing, is being able to create rich metadata that describes this study package in a way that makes it more accessible to people within and beyond our own domain. And just as a final slide here, just a depiction in a sense of the process of starting from the initial CRF, converting that into the common data model, and then using the JSON LD script within the schema.org structure in order to create the metadata that will help to make those data fair. So in swift summary, we know that the CDM is a domain-specific representation, but it may not be understandable to those outside of the domain. Implementation guides of the kind that we've written provide a structure for describing the metadata. And using JSON LD within schema.org can express that structure to make the metadata fair. And web-based search engines can find and access the code to expose the metadata that machines are then able to read. Okay, thank you.
Thanks very much, Keith and Jim. We move on to our work package 8 speakers. Thanks, Anna. And for our attendees, please remember to add your questions to the chat.
Okay.
Thanks.
I would like to confirm that you can see my screen.
Yes, perfect.
Okay. So hello, everyone. Good morning from Washington, D.C. My name is Ana Ortigosa, and along with Ran Lee, we are going to present part of the first piece, the deliverable 1 of the work package 8. This is our also other members or participants of this work package. Repeating a little bit or wrapping up what Alex already said, this package is focused on urban health, and through the project, SalUrbal project, which I'm going to explain a little bit later, through the processes and different methodologies that we apply to gather data and use data from different sources, one of the goals that apply to the WorldFAIR project is the providing recommendations for urban health data that reflect fair and care principles. We were also interested in the data provenance of the data we were collecting from different countries and also different sources. And also because this is something new to the urban health discipline, to contribute of the promotion to good practices in data sharing that could be used within and beyond the urban health field. Well, just summarizing, the deliverable 1 was involved the documentation of lessons learned related to the FAIR data principles in the development of a data platform, which is what Ran is going to describe in this presentation, and also the documentation of cross-domain challenges that we find in the harmonization of national health surveys across Latin American countries. So to give a little bit of a glance of what is SalUrbal. SalUrbal is an acronym in Spanish for Urban Health in Latin America. It's a study, it's a 5-year project, almost entering in the sixth year and having now a new extension. It's a project funded by Wellcome Trust and is focused on almost 370 cities in 11 countries in Latin America, with different goals goals, the main goals that are concerning or related to this project is the analysis of urban data to reveal or to quantify how cities impact health outcomes, health inequities, and environmental sustainability. So for you having an idea, this implies different countries and also different sources of data. We would like to see how the urban environment is associated or related to health outcomes in the population. And so that way we are building a data platform or the data structure that combines sources that of data related to the built environment, to the socioeconomic and demographic data, and also health data. And as you may know, these data are having a geographical references that could be different across them. So one of the challenges was coming up with a flexible structure that could convey or combine or interoperable these different sources of data. And for this, one of the main key things is that we came up with a structure of defining cities, where we called cities as big metropolitan areas, or like the big urban extent of a city. And within the city, we divided it in sub-city structures whenever it's possible, because the city is big enough, which correspond mostly to the municipality or the administrative unit of these cities, and then or the socio-political definition of these municipalities, and then neighborhood that is more related to data referred or reference to the census tract. In some cases, it's more than a census tract, but it's a kind of the lowest level of definition. So I would turn over to Ran to explain a little bit about how we came up with a FAIR implementation in SalUrbal. Over to you.
Yeah, thank you, Anna. So my name is Ran. I'm a data scientist at the Drexel Urban Health Collaborative. Next. Yeah, so as Anna kind of introduced the data, you can imagine really the scope of it, both from us having health data as well as social environment, built environment, and data that spans many countries and many years. One of the challenges was really to think about how to take that data and standardize it in a way that we can make machine actionable. And so roughly this process, I'll talk through a very simple schematic that kind of represent what it does. So we're starting here, for example, let's say we have some census data from various countries. And this was what was happening in the project initially. And then for each of these raw data, we would standardize it into a common format, as Anna was talking about. So on the right, you can see that there are pretty standard boxes which we can do cross-country analysis. Next. And then we have a lot of groups across a lot of countries doing this, but there wasn't really an explicit methodology for harmonizing this harmonized data. Next. And so we initially had this stored on just a server on some folders. Next. And this led to kind of some issues, which, as during the start of our WorldFAIR implementation project, we started to grasp with, which is it was very difficult to access all this data. So we've produced a very rich data set, but due to its complexity, which is a pro, it was also very hard to access. Next. And also accessing it was pretty human intensive. So this would require a lot of manual communication, as well as manual data wrangling and merging before researchers could actually utilize this data. Next. Yeah, next. And so one of the things that we thought about starting our FAIR implementation profile was, if we could have all this data in a single structure, it would enable us to do a lot of things, such as automate data distribution, control access to data, and also start to build analytic tools on top of this resource. Next. And so in terms of the implementation, the first step was to really develop a SolarBall wide, so across all of the working groups, a common metadata standard that was generalizable enough and flexible enough to accommodate kind of the complexities and nuances in the sources of the SolarBall data and how public the data could be at a data point level. And then after we kind of had that standard, our term is renovate. It's basically ETL'd all of the initial working group data into this common structure and then placed it into a single database. And then it was really important for us to build a user-friendly interface for people to interact with this data, as well as some of the downstream products of this data. Yeah, so this is still under the works. This slides are a little out of date, but we're actually publicly releasing this data hub next week. So yeah, but a few lessons is it was really important for us to start embracing software engineering best practices, because I think the other working group mentioned this too, but I think traditional data organizations are now transitioning to essentially becoming software engineering organizations. Software produces data, and so adopting best practices really helped us to get there. Oh, Anna, can you go next? I think I'll go through these individually. Yeah, and so one of the key things for us was adopting version control for our software as well as for our metadata. And it helped us to track our software, and also it has a lot of features for collaboration and project management. Next. And I think throughout this project, it's really fundamentally changed how we think of data, and it's really influenced how we want to pitch research ideas and research projects in the future. Yeah, next. And so to kind of wrap up, I think SolarBall over the past year, so the first year of the FAIR implementation profile, we've really put a lot of effort into moving our data resource into a FAIR state internally. So at this moment, we kind of have our data and metadata in this multi-dimensional data model that has data point level granularity, just to account for the complexity of data sources within SolarBall across countries. And moving into this next year, what we really want to do is collaborate with the other working packages and to go more from closed FAIR, so internally FAIR, adopt some standards such as the cross-domain, the CDIF, as well as schema.org, to be able to integrate within the larger global FAIR ecosystem. So really looking forward to that. Next.
Thank you, Ran. So turning now over again to me, I'm going to explain a little bit more in depth the process of harmonization of national health surveys. As we have mentioned, the motivation for harmonizing surveys was because we were gathering information from different data sources, also trying to connect them to different data structure in the sense of different geographically location or allocation or disaggregation of this data. And one of the ideas of studying the health impacts of urban environment was to have or create this data platform, as Ran already explained, that could combine and allow complex analysis at different levels and assessing different impacts in health population. So in terms of national health surveys, I have to say, well, we gather national health surveys from 11 countries. They were all from a period from 2015 or 2000 to 2015, 19, the most recent ones. There are almost 27 surveys. In many countries, there are more than one wave of these surveys. These are national health surveys that each country release for the purpose of surveilling or assessing incidence or prevalence of different disease. Most of them are among adult population from 18 to 90 plus or 100, and some of them also involved child population through mostly the demographic health surveys. And although the demographic, or some of these are more compiling or are demographic surveys, they may have differences between across different countries. So one of the ideas of harmonizing this is coming up with same or standardization of the way the questions were able to convey the same meaning of the different domains that we wanted to analyze in our study. So one of the strategies that we use for the harmonization is first, or some criteria for the harmonization were the use of existing national health surveys. So this is completely secondary data. We use only surveys that were able to be linked to the municipal level, which we'll call the, as I showed the structure, the sub-city level of the big urban extension. We prioritize differently from the previous work package, non-communicable health behavior and risk factors in the surveys, and we use harmonization approaches that could be rigorous in the sense of standardizing, but also that can accommodate somehow to this flexible structure of different levels of geographical disaggregation. One of the steps, or some of the steps that we use, summarizing the steps, we first identify these surveys and try to collate the questions and response by domain. And also we were very careful about the definitions and the universe of respondents that were intended to reach or to involve in each of these questionnaires. We propose variable definitions and response categories that pay very much attention to the wording across countries and apply harmonization approaches that whenever is possible, not complete standardization, we create multiple versions, or you also harmonization involves unit conversion or collapsing categories when some categories were not exactly the same, even if the question could be same across countries. And we also revise protocols of each of these surveys as needed, and also consulted some or interviewed some people, key stakeholders that were, or entities that released or have governance of these surveys. So just briefly to show how we came up with the different domains in the different adult and child surveys. Mostly the surveys that we collected were among adult population. From these domains, physical activity and depressive symptoms were the ones that were more easily to harmonize or standardize, just because they use usually in the surveys also questionnaires that are standardized already. Although there were differences in the wording or in the adaptation of each country, these were the most easy to standardize or harmonize. However, diabetes, hypertension, self-reported health, they have challenges in the way they consider not only the wording, but also sometimes categories that are different across countries are not able to one-on-one or vis-a-vis to be harmonized. And I'm just remarking here also violence, because this was a domain that we consider highly important and was not very represented in all of the surveys that we collected. Regarding child surveys, these domains are less comparable and harmonizable across country. The only one that was easily to standardize was the anthropometry. So in terms of the challenges of survey harmonization, and I have to say this was, as Ran commented before, very manually, or involved a lot of people working on doing the harmonization of the different domains, because imply interpretation and also trying to disentangle the disagreements in the definition of risk factors. Also, lack of consistency, as I was explaining, the categories or the measurement units used for an indicator. And finally, discrepancy. When we have standardized questionnaire, there were also discrepancies in the scales that were used for retrieving similar information regarding health behavior or health outcomes. For example, some countries were using questionnaires for physical activity, but some of them use a standardized questionnaire that was different from the other. So one of the things that we wanted to aside from the use that SalurBot gives to this data, one of the implications that we see beyond the project is the idea that we can do some recommendations of good practice to countries because they have autonomy to generate these surveys, but also how good could be that we can contribute to work with countries in the design or the assessment of questionnaires, future questionnaires that could be more comparable across countries. One of the outcomes of this deliverable was the generation of this 10 points or 10 good practices and recommendations that we mostly, this is also for our use, but mostly I think it has a good point for discussion at the different countries who owns or who handle these surveys in different waves. I would like to acknowledge the rest of our team, not only at the SalurBot project, but also in this work package that greatly contribute to this, and the people that also work in the renovation of the data platform we run. Thank you very much. And this is, if you're interested in knowing more about the SalurBot project, these are the social media and the contacts. Thank you.
Thanks very much, Anna and Ran. Thank you to all of our speakers. So I don't see any questions in the chat. So I think we can proceed with our panel conversation. Attendees, please remember to post any questions in the chat or raise your hand if you want to ask a question to our panelists. So for the panel, we are joined by Sama Bilal from the Drexel University. And as we've established, the WorldFAIR project has a very strong cross-disciplinary component. And the overarching topic and theme for this panel conversation is to discuss and identify commonalities between the two case studies that we have been discussing so far. So our first sort of theme or question for our panelists is, what common challenges for FAIR implementation in urban health and population health have you identified? Who would like to go first?
Can I jump into there?
Of course.
What I'd like to say is, I think everyone in population health, and especially the data producers and the users, recognize the need for FAIR data, recognize the need for sharing data, recognize the need for harmonizing and using that data to answer important questions. But I think there's a lack of awareness of how to actually do that with their own data. And I think that's came out in the presentation by the Urban Health as well, that there's an understanding of the need, but very little understanding of how to actually do that with their own data.
Jim, I want to
add. Oh, I'm sorry, Ran, go ahead. No, I was just going to say, I think that also what Anna and Ran were able to describe extremely well is a common occurrence of data being collected, which is similar to itself, but not collected in quite the same way, and having vast quantities of that, and being able to standardize that in a way that's meaningful and can be reused is such a sort of major first step to be taken. And you've clearly recognized that very clearly and have done some really impressive work to try and bring diverse data together in a way that it can be used more meaningfully. And I think that's a very common issue for any of us working with these kind of population and survey records.
Yeah, to kind of piggyback on first, Jim, your point, I think, I don't know how you felt, Anna, but when I first came into this project, I understand the principles, but I tried to Google, but there really were no resources about implementation. And I think that's just the stage of where this global fair movement is that we are starting to recognize it. I'm really glad that World Fair is putting this project to focus on implementation. And I think we're in this stage where everyone is kind of finding their own paths. And I think there will be a convergence if this kind of larger global effort like World Fair continues. So really excited to see how that goes. And yeah, and Keith, I agree. It was, I think people want to do it. The tooling, I don't think it's there yet, especially in our case. I don't know about your institution, but we're a very academic institution. So we kind of have this approach of, oh, we got the manuscript out. Nah, that's it. But, we put so much work into, collection, harmonization, and just add a little bit of effort, and you can really make this a much more valuable resource. So
yes, I agree completely with that.
I don't know if Sama, you want to say something, but I have also some remarks, but
go ahead.
No, I was saying that, yeah, I think the challenges are, as Ran remarked, the challenges of the disciplines itself, like this is something concerning, or we are doing this in an academic context, but I think the implications are beyond that. But when we start to think about how we make this data more interoperable with other data, so they can better explain the inequalities or the inequities that are happening at the population health in our region, this is also going beyond the main goal of academic research, that is, describing or understanding this the determinants or the role of these inequalities. And when we are doing this process of FAIR data, what I think the future challenges are related to governance, to data governance, and how we can engage countries or the stakeholders of these sources of data. Because I think one of the characteristics of this service is that we don't own them, or we don't have any implications directly to how they can release this data. But I think we can do a very good effort to make this convening of these stakeholders that are key actors in these sources of data, to make that make the FAIR reach out to them also, to see how important it is that we have common language, common understanding of how important is comparing and accessing to this for the use and also decision making as well. So I think I see these implications beyond the research, and seeing this more as a kind of powerful tool for equity, right? So
Just wanted to add that to what Anna said, Anna and Ran, that I think in a way we had to do this effort twice. We first had a lot of different countries with a lot of different things, as Ran showed, and then that had to be put in some sort of common format. But then we realized that there was a second level of that, where all of those different things had to have common schemas amongst themselves. And that second stage only happened, I think, because we had a mandate to share the data publicly. Had that not happened, it would probably have stayed the way it was before, because the effort to do this was very high. But I think we are now seeing the advantages of, even though we were mandated to make it public, and therefore we had to go through the FAIR process to get there. And I'm not sure we would have done that had we not had that mandate. We are now seeing the advantages of having done that FAIR part, because we've always, as Ran showed, we've always been thinking, like, how do we even tell people what data we have available? Yes, we have long documents, very precise, very accurate, etc., but we cannot search there for income and do that, right? So this process has actually helped us a lot show this data more broadly, even internally. Even though the main impetus was external, it really has benefited us internally now. But I think it's hard to get that buy-in without having a vision of how that can look like in the future. And I think this can be a good example of how that can look like.
Thank you. Yes, and touching a little bit on following up from Anna's remark, we want to expand a little bit on the challenges for FAIR implementation in the specific regions and areas where your case studies were carried out. With work package 7, I'd like to add, perhaps?
Okay, should I jump in again at the beginning? I think that the specific challenges that we had, I mean, and I suspect, most people who are working in this, is that there are very little resources for population health, for making population health data fair, and not just for making them fair, but also the resources for actually describing the metadata, the resources for getting the right vocabularies to describe the concepts that we're trying to measure and trying to bring into our data. And so I think there's a need for, I think population health data here has been a very poor, distant second cousin to the more clinical data collection, whereby lots of the resources are suitable for clinical data, but are not suitable for describing conditions which are being experienced in communities by people in their own homes. Thank you. Sorry.
A challenge we had ourselves on this side of things is that we've realized of that challenge even more now with the open data sharing, is that, well, data is political. I think that's, to me, especially data that relates to cities and data that relates to population, is very political, and therefore sometimes we do have a challenge in what we can share, not because of privacy concerns necessarily, but because there is a lot of politics around this kind of data, like population estimates, etc., that then determine which municipalities get which resources, etc. So sometimes the data is not so openly shared by countries, and they do share it with us for research purposes under very restrictive conditions, and then that we cannot make that public for that reason. So while we are going through the FAIR process, with the impetus of making it public too, we have to wrestle with this idea that there's a whole lot of, not a whole lot, but some data that we are going to be verifying, but that no one will ever be able to see that because there are reasons that are completely beyond our control in that case. I think that's a big one for us.
Thank you. Would anyone like to add? I am aware of the time. We have 5 minutes left, and I don't see any questions from the audience. Maybe we can touch on a third question. So we've discussed the challenges, we've discussed individual challenges and the common challenges. So looking forward, do you identify any potentials for collaboration and future work between the two case studies?
I think I will jump because this at least I think these webinars are a good way, not only for the audience, but also I think between work packages to learn a lot in a very compressed time about what they are doing. Although we got this opportunity to monthly meet, sometimes this idea of see everything, have an overview at a glance. I think the work package 7 was very interesting because they depart from somehow a standardization that they already have of the surveys and mostly infectious disease surveillance that we are not at the Salud World project. We haven't had that opportunity yet to compile data. So I think that experience is very interesting. I think for the machine actionable harmonization of surveys in the Salud World project. So I see there some synergy or some potential learning from this work package from the work package 7. So I'm glad that we got this opportunity to be together in this webinar.
I agree completely, and I think that because one of the cornerstones of FAIR, in a sense, is this idea of interoperability and how can you meaningfully share data across different domains. And what's key to doing that is to know what the other domains are doing and what the issues are that they are facing and how they are handling data. So I think it's extremely useful to know in some detail the work that you're carrying out, some of the challenges that you're facing, because they're similar to some of the challenges that we faced. And I think, ideally, in a perfect world, we'd reach a point where there was the ability to sort of interchange data between us in a way that would make it greater than the sum of its parts. It would become more meaningful. And I think that that's something that FAIR is striving to do. It's extraordinarily difficult, but I think that's something that FAIR is aspiring to do. And so knowing what you're doing is really helpful in that regard.
Just to add to those 2 points, I think also the other thing I really enjoyed from the urban health was the way they approached the governance and the bringing out of different people into the decision-making process for urban health. And I think that's going to be something which is going to be very important, is how do we engage with people, with the communities, with the different data producers, data owners, and the policymakers, to make sure that this is something which encompasses all of their needs and desires. Yeah, so I thought that was interesting.
For me, I think what stuck out, sorry, Alex, just a quick point, is I'm glad, Jim, in your presentation that you kind of mentioned JSON-LD, schema.org, and the cross-domain interoperability framework. And I think for us moving forward, those are definitely things that we're going to be exploring and looking forward to learning from both your working package as well as I think Aerofan's working package. As it's going to be really exciting to collaborate on that.
Okay, thank you all very much. And one last call for questions from our attendees, with 1 minute left. No questions. So if you are interested in the case studies and the work that they're doing and in the project as a whole, I have put the link to the project website in the chat. But so if people want to be involved in your project, this is a question we get in other webinars, so I'm going to go ahead and ask it. So if somebody wants to get involved in your case studies or in future work, or find out more about your work other than WorldFAIR usual channels like our newsletter and website, is there any other way to reach you?
I see links to our project website and the data portal that run present. If you want to explore the data portal, it's there. We are going to be making a few changes these days, but it's launching officially next week. And then the project and the newsletter and how to get involved with Salurbal is the second link.
Thank you, Sam. That's great.
And certainly the website for Inspire is the way that we should, way that they could contact us, but also to email either Keith or myself. It would be very useful as well.
Yeah, I know that may sound a bit low tech, but that actually is probably the best way of getting directly to those of us most closely involved.
So 1 minute past the hour. I still don't see any questions from the audience, and unless any of our speakers and panelists want to add anything to today's discussion, I think we can finish.